Welcome all of you for this PG entrance discussion class. Today is our session 4 of the class. So today we have Dr. Kartik Hirekal, who is currently working as an assistant professor in JJMMC Davangere, and he's also my batchmate from my MBBS days, and also a good friend of mine with whom we had all adventure and trekking and everything. And he's not only a good academician, he also has a very good academic career, being a graduate and a postgraduate and also senior residency from esteemed institutes across the country. So I think he's the best person for you to take through your journey through this ENT part of your entrance preparation. So feel free to ask him any doubts, and don't just think that this as a one-way learning. Any doubt you have during your preparation time, you can ask it through your personal message or in a group message. You can just text him, WhatsApp him, whatever doubt you get, any reference you want. Feel free and make use of this platform very well. And I hand over the session to Kartik. Continue, Kartik.
Good morning, everyone. Today I'm going to discuss core topics on larynx, what the trend has been going on right now regarding to the questions on MCQs on larynx. Okay, so first slide I have kept it blank so that you concentrate properly, because these things you might not have read in your ENT time, because those time we used to teach you as whatever superficially, but nowadays I am seeing questions they are more management oriented. So whatever keep it aside and just concentrate. Mine today's class will be more on MCQs are there, but more on I'll try to explain the things. Okay, so first question, this question you might have seen. I think there's a recent AIMS, they have asked 30-year-old female underwent total thyroidectomy for papillary carcinoma of thyroid. Immediate post-operatively, she developed stridor and cyanosis. Which of the following not be a part of management of this case? Okay, so the options given were Kashima surgery, emergency tracheostomy, laser this certain spelling mistakes. Just pardon me. I'll just if any spelling mistakes are there, just correct it. Laser chordectomy and type 1 thyroplasty. Okay, so going to this question, what you think the answer is? You can type it in or you can unmute and say, or else I'll go ahead with telling the answer and I'll go ahead with the discussion on this topic. Okay, the answer is type 1 thyroplasty. Okay, so we'll go ahead with the how to solve this question. Okay, so the question asked is total thyroidectomy is done. Okay, so you and post operatively while intubating they will give different scenario. While extubation, while extubation, anesthetist have difficulty in extubation, or patient will go into cyanosis, patient goes into stridor. Okay, the different scenario they will give, they will bring out the anesthesia role over here. They will just post the anesthesia as having difficulty in extubation. So those things suggest what, there is a nerve involvement immediately after surgery. Something is happening, means already patient is on table. So if any bleeding is there, you can get to know. So the one of the option, what might be the cause, one of the option, if the question is what might be the cause, one of the option will be hematoma. You don't run ahead and mark hematoma, because if bleeding is happening, surgeon will be there only while extubation, so they will get to know. So it is mainly the and we would have put the this thing drain. So it is mainly the some nerve injury has happened. So what nerve injury has happened? There is a recurrent laryngeal nerve injury has happened. So this nowadays I am seeing lot of question is being asked on thyroid surgery, implication of nerve supply to the larynx. So coming to the nerve supply to the larynx, there are two nerves which mainly supply to the larynx. One is the superior laryngeal nerve, other one is the recurrent laryngeal nerve. This picture you are seeing, no, this is one what we are seeing from the behind. If you take out the spinal cord of the patient and if you look at it, this picture you will see. So we are seeing the thyroid and the esophagus trachea from the behind. See, you can see the This is the esophagus. This is trachea. Okay. So then coming to then coming to the nerve supply. So nerve supply, this now whatever you are seeing is the vagus nerve. Okay, it gives superiorly the superior laryngeal nerve, and from inferiorly recurrent laryngeal nerve. Recurrent means why? But it is vagus is crossing the thyroid gland and crossing the larynx. Then it is giving a nerve for the larynx. So the nerve is called hello. Then the nerve is called recurrent laryngeal nerve. So the word. So first I will go with the one by one nerve. Okay, first one is the superior laryngeal nerve. So superior laryngeal nerve is given where? It is given at the, you can see where it is given. It is given at the greater corner of hyoid. This is the greater corner of hyoid. This region it is given. Okay, so superior laryngeal nerve is given. Okay, so this from superior laryngeal nerve, what it comes along with the, this is the superior thyroid artery. So see how much near is the nerve to the superior thyroid artery. So till here you can see the nerve is following the superior thyroid artery. So one nerve is going like this. This is the external branch of superior laryngeal nerve. This one is the this goes into the, sorry, this is internal branch of superior laryngeal nerve. So here see it is piercing the thyrohyoid membrane. This is the thyroid, this is the hyoid, this is the thyrohyoid membrane. So this is internal branch is piercing over here and going to the larynx. Though external branch is descending, it descends and gives where? It descends and gives supply to the cricothyroid muscle, supply to this cricothyroid muscle. So this forms the sensory branch, this forms the motor branch. So sensory branch, it gives what? It gives the sensation to the larynx above the vocal cord. So related to, so I told you it is related to superior pedicle. On injury, what happens? Suppose if you have injured this nerve, how the surgeon can injure this nerve? While clamping the superior pedicle. So there is one more question is there. In recent exams, they have told while clamping the superior pedicle, surgeon has injured the nerve. Okay, they haven't told about the nerve. And what is the implication? What is the implication in the patient? What are the symptoms patient can have? So as I once, if you injure this nerve, what happens? There is a cricothyroid muscle will become denervated. So what is the function of cricothyroid muscle? It will tenses the larynx. What do you mean by tensing the larynx? It will make the vocal cord stiff. So vocal cord, if vocal cord becomes stiff, means what happens? Person can raise the voice, singers or else who shouts and speaks. No, that time the vocal cord should be stiff. So that is done. One vocalis muscle and cricothyroid muscle will does that work. Okay, so this cricothyroid muscle gets paralyzed, means person can't raise his voice. Okay, singer can't raise his voice. So what is the options were given? They have given stridor, hoarseness, those and all. So they will try to confuse you. Moment nerve injury, you will go with the stridor or hoarseness. So always it is impaired voice production. Okay, impaired voice production, and there is a aspiration because even the internal laryngeal nerve has gone. So there is a sensory supply to the nerve has gone, larynx has gone above the vocal cord. So it can lead to the aspiration or penetration into the larynx. But vocal cord is sensitive because recurrent laryngeal nerve gives the sensory to the vocal cords. Okay, so how it present? Again, they may give repeated cough or the hacking sensation. Okay, repeated clearing the throat sensation. Such sensation you will get whenever there is a superior laryngeal nerve is injured. So the by superior laryngeal nerve, what all question they can ask? One is the, it is the nerve which gets injured while clamping the superior pedicle. So in your question, there is a superior pedicle clamping, there is a nerve injury is there. You should think it is a superior laryngeal nerve. Then what is the, they will give, what are the symptoms patient can have? It is a impaired voice production, or patient can't raise his voice, and there is a aspiration can happen. So these are the questions they can ask on the superior laryngeal nerve injury. Okay, then coming to the recurrent laryngeal nerve. So where it runs in a tracheoesophageal groove. You can see this is esophagus, this is trachea. Okay, in between that it is running. It is a recurrent laryngeal nerve. Okay, left is more prone for injury than right. Why? Left one comes from the, you can see over here. See this right one, this is the right. Okay, we are seeing from behind. So this is the right side, this is the left side. So left side you can see it is still down. It comes from the arch of aorta. It hooks around the arch of aorta, but here it hooks around the brachiocephalic. This is the brachiocephalic artery. This is the carotid artery. Okay, it hooks around the brachiocephalic artery on the right side. It left side it comes from the arch of aorta. So any mediastinal lesions, okay, lead to the recurrent laryngeal nerve palsy. So one classic syndrome, you know, Ortner syndrome, where there is a mitral stenosis will be there. In that left side recurrent laryngeal nerve is more prone for injury. But there is a twist. When surgeon is going to injure that nerve, if by mistake surgeon is injuring the recurrent laryngeal nerve, which side recurrent laryngeal nerve will get injured? It is always the right sided recurrent laryngeal nerve. So remember, during surgery it is right side, or else most commonly injured is the most common palsy happens is the left side. Okay, if a surgeon is injured, means why? Because you see this runs in a esophageal groove very early in its course, but here you can see this oblique is there. See the distance between the recurrent laryngeal nerve and the esophagus, there is a distance. So though while dissecting the lower pole and all, surgeon can injure the recurrent laryngeal nerve. Okay, so then they will ask what is the most constant landmark for the recurrent laryngeal nerve. So it is the tubercle of Zucker-Kandel. Okay, it is there in the thyroid. Okay, tubercle of Zucker-Kandel, which is the constant landmark for the recurrent laryngeal nerve. Okay, so what is the function of it? It gives the sensory supply below the vocal cord and below the vocal cord, and motor supply to the all laryngeal muscles except cricothyroid muscle. Okay, cricothyroid is given by the external branch of superior laryngeal nerve. Okay, so what happens? Very, very important, bilateral injury. So whenever there is a recurrent laryngeal nerve, both side it got injured. So what happens? There is a normal voice, because I will tell next. There will be a very, very important. You should remember, whenever the recurrent laryngeal nerve injured, don't go ahead and type it as there is a hoarse voice is there. So when bilateral injury is there, there is a normal voice. Whenever unilateral injury is there, there will be a breathy voice. Okay, this is I'm telling about bilateral injury. Then what will be there? Stridor will be there. Then cyanosis and aspiration will be there. Okay, so how it happens? See, this is the bilateral injury to the recurrent laryngeal nerve. It is also called bilateral abductor palsy. Why? I told you the this thing, recurrent laryngeal nerve supply all the muscles of the larynx, but why abductor palsy will happen, I will tell in the next slide. Okay, so remember, it is a bilateral abductor palsy. So what will be the position of the cord? It is called cadaveric position. Okay, very slit like airway will be present. So patient will have a stridor, but the air leakage will be there, so patient can have a normal voice. Okay, there will be breathing difficulty will be there. Okay, voice will be normal. So different location, you know, different location according to the size. This is classically given in your Dhingra. So also the first one is the median, midline it will be there. Then paramedian 1.5 centimeter millimeter from the midline. Intermediate or cadaveric, it is 3.5. Partial abduction is 7. Full abduction is, okay, just a minute. Full abduction is 9.5 centimeter. Okay. So coming to the why this abductor palsy will happen, why there won't be a adductor palsy? Because it runs according to the Simon's law and Wagner's Grossman's law. What it states? It states all progressive organic lesions, abductor fibers will be affected first. Though just remember, first fibers will be abductor fibers, because those are the phylogenetically newer ones. Okay, this also says same. Okay, Wegener's and Grossman's law. Okay, so finally, if there is a bilateral injury to the recurrent laryngeal nerve is there, so what happens? Only cricothyroid muscle will be acting due to external branches. This branch is intact, it gives cricothyroid muscle supply. So the it will comes and lies in a cadaveric position. Okay, this is the picture they will give most of the time. If they say after post extubation, this is the laryngeal picture. So what is the condition? It is always it is bilateral abductor palsy. Okay. So what are the treatment options? So what are the treatment options? There is airway is not there. So immediately you have to create the airway. So first option will be the emergency tracheostomy. Then after doing tracheostomy, what is they will give the question like that too. Tracheostomy has been done. What is the next statement? What is the next treatment? Don't go ahead. Today you have learned Kashima surgery, suture lateralization. Don't go ahead and mark those one, because always till 6 months you have to wait and watch for the spontaneous recovery. It is a nerve injury. It will recover. So you have to wait and watch for the 6 months spontaneous improvement. If it is not happening, so ultimately you have to take out the tracheostomy and patient has to breathe through the normal larynx. So what you will do, you will create the space. How will you create the airway? You will create the space. So there are different type of surgeries are there. First surgery you should remember is the Kashima surgery. It is most asked question. What is Kashima surgery? Kashima surgery is they'll by laser they will evaporate the vocal process of the arytenoid. See here the arytenoid is there. So they have with laser they have evaporated it and they have cut the even the posterior 1/3 of the larynx and creating the airway over here. See, so there is a airway has been created. So this is called Kashima surgery. Or else they'll put a suture and they will lateralize the larynx and this suture will be tied at the externally through the thyroid cartilage. They will bring it out and they will tie it to the thyroid cartilage externally. So the airway is created, suture lateralization. Okay. So then coming to the thyroplasty. Which thyroplasty you will do in bilateral abductor palsy? It is lateralization. Okay. Lateralization. Unilateral recurrent nerve palsy, I told you breathy voice will be there. Which surgery will do? Medialization. Okay. So here is the lateralization surgery. How will you remember this one? How will you remember this thyroplasty? They will ask different multiple questions can come with this. Medialization type 1 thyroplasty, where you will do? You will do it in a unilateral palsy of the recurrent laryngeal nerve. In abductor palsy or bilateral palsy, you will do the lateralization. First you will be doing the emergency tracheostomy, waiting for 6 months, then you will be doing the type 2 thyroplasty. Then puberfonia, then androphonia. So what you mean by puberfonia? Child-like voice. If a when a male grows, reaches puberty, he will be having a his voice will be pitch will be lowered. But what happens if constantly pitch is high? It is called puberfonia. So you have to lower the pitch. How will you lower the pitch? You will shorten the vocal cord and you will lower the pitch. So how will you raise the pitch? You will lengthen the vocal cord and you will raise the pitch. Okay. So androphonia, if a female is having a male kind of voice, andro means male kind of voice. So androphonia, wow, in female is having androphonia. So such patient, if you bring back the voice, means you have to do the lengthening of the vocal cord. That is type 4. So how will you remember it? So 1 second, I can see your pictures only. So how will you remember it? You should remember MLS. Okay, MLS for larynx. So whatever the surgery done in the larynx for benign lesions, what you will do? Microlaryngeal surgery. So you remember the word MLS larynx. Okay, M for medial, lateral, then shortening, then length. So MLS surgery is done on the larynx. So MLS stands for the, you should remember, Ishiki thyroplasty. Type 1 is medial, type 2 is lateral, type 3 is shortening, type 4 is lengthening. Medial is done for unilateral palsy. Lateralization is done for bilateral palsy, or else it is called bilateral abductor palsy. Then third one is done for the, if a male person is having a child-like voice, that is called puberfonia. If a female person is having a male-like voice, that you will be doing a lengthening. Okay, understood? Am I audible clearly? Anyone can unmute and say, am I audible clearly?
You are very much audible, Kartik.
Okay, okay.
Going on very nicely. You can continue.
Okay, okay. So this multiple question they may ask. They may ask clinical scenario in a patient post-operatively one side recurrent laryngeal nerve is injured. Which is the following management? There you should not mark the emergency tracheostomy because their airway is there already. Abduction is happening. Only the media one side it has gone. So what you have to do? There is a one side palsy of the vocal cord is there. So there is a extra leak of air is happening. So you have to reduce that extra leak of air. So what is the extra leak of air? The voice will be called breathy voice. Okay, that you have to stop. What to stop? What that you have to narrow down the larynx. So how will you narrow down? You have to medialize. So that is called type 1. Lateralization. Lateralization is means there is abduct, both side larynx is not moving laterally, so airway is not widening, so you have to widen the airway. That is called lateralization, is type 2. Then coming shortening. Shortening means, you also remember puberfonia. Puberfonia means childlike voice. Child is a compared to adult is child, child will be having a shorter, child will be a shorter, so it is a child type voice, you have to make it short. Okay, so you can remember like that also. Puberfonia for shortening, androphonia for lengthening. Okay, how will you remember type 1, type 2, type 3? You have to remember one more surgery done on the larynx for all benign lesion of the larynx, which is the surgery is called MLS, microlaryngeal surgery done on the larynx. So MLS larynx. Okay. So this is one image based question. So they may ask you, they will put the this what is this? It is a endotracheal tube. They will put it and they will ask which surgery it is used. It is used in any head and neck surgery. They will use to monitor the intraoperative monitoring of the nerve to prevent this all injury. Till now I told surgeon going to injure, surgeon going to injure. So something you have to prevent, no, beyond knowledge of the surgeon. If surgeon, you may say surgeon is injuring without some knowledge, might also. Beyond that one, you have to intraoperatively you can monitor nerve, whichever structure you are cutting. No, you have a doubt means you can excite that nerve and check, and whether if it is nerve, the machine will make a certain kind of sound. So how will you do it? You will put this ET tube. You will put this endotracheal tube. What is the difference? It will be having a electrode over here. So, and outside also you will be putting a one ground electrode. Wherever the you are having some doubt on some structure, before cutting it, you just touch with another probe. The machine will make sound. So for that, it is called nerve monitoring endotracheal tube, used in any head and neck surgery, mainly in thyroid surgery, because nerve injury is more common in a cancer condition, because the nerve will be invading the nerve will be invaded by the mass. So that is the reason most of the time this nerve injury happens in a cancer surgery. So you will be using, so they may put this till now not asked, but it may come, it is sure shot, because they are asking many advanced pictures. So this is one not much advanced, so it may come in further days. Okay, just remember, if an endotracheal tube is there along with some wires are there, so it is a nerve monitoring endotracheal tube used in head and neck surgeries to monitor the nerve, mainly in the thyroid surgery. Okay. So coming to the next question. Okay, 30-year-old lady underwent hemithyroidectomy. Remember, it is one side thyroid has been taken out. Okay. So while clamping the upper pedicle, surgeon has injured the nerve. Which of the following patient may have in post-operatively? So I told you, hoarseness of voice. Okay, the stridor, difficulty in raising the voice, aspiration, which is the most commonly, it will be the difficulty in raising the voice. Okay. Then treatment of the puberfonia. So what you will do for the puberfonia? It is type 3 thyroplasty. Okay, type 3 shorten. Okay, MLS, S is short for the shortening. Okay, then this is also a recent question. 43-year-old female suffering from the follicular carcinoma of thyroid has recently undergone total thyroidectomy. During surgery, her both superior laryngeal nerve got damaged. Which is the post-operative symptom of this patient owing to this complication? Again, same question like this one. So it is always, it is not respiratory difficulty in normal voice. It happens in a bilateral recurrent laryngeal nerve or abductor palsy. Poor voice quality. Yes, this can happen. Okay. Then aphonia with aspiration. Okay, aphonia can't happen. Patient can able to speak. Okay. Then poor voice with the aspiration. So only poor quality of voice, no, there can be a aspiration also. Okay, poor quality of noise and the aspiration is the answer. Okay, then coming to this is a recent AIMS question. So they have, sorry, NEET or AIMS, I think, recent question. So a mother gets her child to the doctor with a complaint of child is not able to swallow anything since past few hours. Okay, remember past few hours. Okay, it is an acute case. She is not sure about but says that child was playing with a coin. On examination, vitals were stable and there was no dyspnea. Okay, what is the diagnosis? So they have told vitals is not stable, there is no dyspnea. So they will definitely give an investigation picture. So they have given a picture, okay, and they have asked where is the foreign body. So foreign body is whether it is in trachea, esophagus, or soft tissue of the neck, or foreign body is in a prevertebral space. So how will you get to know? By this picture you can't get to know where it is. You can get to know which level it is. It is at the entrance of the chest, okay. So it is at the entrance of the chest. So but to see which structure it is there, you have to take a lateral decubitus view, okay. So it is lateral view. It is showing, you can see the airway in front. It is there here, okay. It is there in the esophagus, okay. Behind that one, soft tissue of the vertebra will be there. So it is there in the esophagus. Where it is there? Commonly it will be there below the cricopharynx. Remember, they may ask a question, where is the common place for lodgement of the foreign body? In the esophagus. In there it is post cricoid region below the cricopharynx, because cricopharynx it won't be stuck, because there is a inferior constrictor muscle will be there. It will constrict, so it will be slipped into the just below the cricopharynx, okay. So go ahead with the question. Always you have to take a lateral view. So here you see, this is the how the patient present if it is there in the trachea, okay. So you can see by the slit also. Here anteroposteriorly it is a slit like appearance, because trachea is a round structure, esophagus is a anteroposteriorly flat structure, it is collapsed structure. So coin will lodge like this in the esophagus, but always it is confirmatory is by the lateral view only. See here the airway is there, coin is sitting in the airway, it is there in the trachea, but if it is there in here over here, it is called esophagus, okay. So same here you can see, this is the next question regarding to the x-ray. I am going ahead with the next question. What other question can come on the x-ray? So you can see the epiglottis sign. So how will you see thumb sign? You can see the epiglottis over here, it looks like a thumb. Here you see epiglottis looks like a leaf, okay, looks like a leaf over here. This is hyoid bone, beyond that one is the epiglottis. This looks like a leaf. This space is called vallecula, okay. This space is called vallecula. Here this is the base of the tongue, this is vallecula, this is epiglottis. So if epiglottis turns like a thumb, means it is a epiglottitis. So coming to the another sign, what you will see in regarding to the x-ray, it is laryngotracheal, okay, croup or laryngotracheatis. You see pencil like, you can see the pencil like, no, it is called, also it is called what sign? Hello,
Steeple sign.
yeah, steeple sign, okay. So they will ask you, so how the questions will come on this? Okay, one more I left. So this one x-ray, you can see widening of the prevertebral shadow. There is a air pockets also there. This suggests the retropharyngeal abscess, okay. This suggests the retropharyngeal abscess. These all clinical scenario, they will give x-ray and they will ask, okay. So what you will do? I will go ahead with the next slide. So what are the infections happening in a child, acute laryngitis in a child, which can have a different clinical scenario? Simple laryngitis, they will never ask, but I'll just go with, it can happen in any age, okay. Onset will be gradual, it will be morely viral etiology, okay. Temperature usually initially it will be normal, but the voice will be, hoarseness of voice will be there, because larynx will be majorly affected. Then posture, there won't be any classical posture defined in this. Treatment is always conservative treatment, okay. Monitoring is not required, you can send the patient to the home with a conservative treatment, okay. Then coming to the subglottic involvement, it usually happens in a 1 to 4 years, okay. Onset will be rapid, because subglottis is the narrowest portion in the child, so the immediately child will have a breathing difficulty. So onset will be rapid. Many causes can happen, it will lead to viral, bacterial, or an injury or intubation injury, can lead to the subglottic inflammation, okay. Then temperature will be, usually the temperature will be near normal, okay. Then voice will be, again it will be a harsh voice will be there, okay. Child will be restless, okay. And support patient, you have to moist air and supportive treatment you have to give, okay. Child should be no need of that much active monitoring over here. Coming to the laryngotracheatis usually 1 to 8 years, so they'll give classically, because this is epiglottitis is 3 to 6 years, so they'll give little older in your question, okay. 7-year child, 8-year child, like that. Okay, onset will be gradual. Here it is epiglottis is rapid. Okay, in fact here it is the bacterial origin. Okay, temperature, again the temperature will be there. Voice will be hoarse voice. Okay, okay, patient will be lying down. How you have to do? You have to treat with the antibiotic, and if required you have to do the intubation also. Okay, you are actively monitoring the airway. Then epiglottitis, again it is 3 to 6 year, classically rapid onset, caused by Haemophilus influenza. High grade fever will be there. See here and all, fever will be not much defined, but in epiglottitis there will be a high grade fever. Drooling of the saliva will be there. How will be the voice? Voice will be normal, or sometime it will be a muffled voice will be there. Okay, child will sit like a tripod position. Child will bend forwards and it will sit. Okay, so they may they may give the picture of the child in a tripod position rather than giving a X-ray with a thumb sign. Okay, so what you will do? You have to give antibiotic. You have to, if required, if narrowing is there, you have to do intubation also in a patient. Okay, then active monitoring is required. So this is how the different clinical scenario they will give. Okay, so X-ray if they give means you have to look for a thumb sign or steeple sign. Okay, steeple sign, remember they may ask a point question also. Steeple sign seen in laryngotrichitis. Okay, so thumb sign seen in, and then give a clinical scenario. Here the fever will be there, epiglottitis. There will be a drooling of the saliva will be there, dysphagia will be there in the epiglottitis, but in laryngotracheitis it is not much defined. Okay, then in treatment is almost same both side. In not, you should not run ahead and go the tracheostomy. Okay, you should always intubate the patient. Okay, if there is after intubation, if it is prolonging means you do the tracheostomy. If patient is prolonged intubation required means you do the tracheostomy, or else you will see for the leak test. Okay, they won't ask you. If the edema subsides means there will be a leakage of airway around the intubation tube, so that time we can extubate the patient. Okay, so this is on scenario they may ask. So above picture shows the bronchoscopy. You can see the two ports over here to ventilate the opposite lung. This will be ventilating the lung which you have put into the bronchus, means it will be ventilating the right lung, but left lung, how it will get air? It will get air through these ports over here. So this, whenever this ports is there, it is always the bronchoscope. Whenever it is flat and there is no ports are there, it is always the esophagoscope. Okay. Okay. Next question. CT scan of a patient of carcinoma of larynx found to be involving epiglottis and false cord on right side, along with the involvement of right vocal cord and pre-epiglottic space. What is the ideal management of this patient? Okay, these are the options: chemoradiation, partial laryngectomy, total laryngectomy followed by chemoradiation, chemotherapy. Then next question: patient with a carcinoma of larynx found to be involving the epiglottis or epiglottic fold, but both the vocal cords are free from the mass and mobile. What is the ideal way of management? Total laryngectomy, vertical partial laryngectomy, radiotherapy, horizontal partial laryngectomy. Okay, so we'll go ahead how to solve this question. Okay, rather than telling answer, if I explain you, so you should know the staging of the larynx. So how will you do the staging of the larynx? The left side picture shows the elaborate staging of the larynx, but you have to how to remember it. So always remember T1. T1 means it is involving the only one subset, epiglottis. So aryepiglottic fold, vocal cord, false cord, PFS, piriformis fossa. If it is only one subset is given in your exam, okay, given in your question, it is always the T1 staging. If there are two structures, two subset are given, epiglottis and the base of the tongue, epiglottis and the false cord, epiglottis, aryepiglottic fold, PFS, aryepiglottic fold, vocal cord, false vocal cord. If two subsets are given, it always goes to T2. So there can be impaired vocal cord movement whenever it is in a T2 glottis, whenever the mass is sitting on the vocal cord only. If it is more than its size, there can be impairment. Okay, but in supraglottis it is not. That is the difference. If T2 glottis is there, vocal cord malignancy is there, impairment is also T2. But always T3 means in your exam, T3 always they will give either a fixation of the vocal cord. They will give vocal cord is fixed, or else how, what other question they will give? Hemilarynx is fixed. Hemi, one side larynx is fixed. And other spaces, what are the spaces? Pre-epiglottic space, paraglottic space, post-cricoid space. I haven't mentioned over here. Post-cricoid space. These all will become T3. Okay. Then any invasion to thyroid, cricoid, or beyond, esophagus. Okay, involvement of thyroid gland. Okay, beyond the thyroid cartilage, it is coming out. Cricoid, it is coming out. Cricothyroid membrane, it is coming out. It is involving the vertebra. It will involving the spine. Prevertebral muscles. It is involving the extrinsic muscles of the tongue. Not only superficial involvement is not T4. Extrinsic muscles of the tongue. So these all will come into the T4. So this is how you have to make out. So coming to this question, what is epiglottis? Here what is given? Epiglottis, false vocal cord. This much it is given means it is a T2. But along with that they have given right vocal, it is involving right vocal cord, and fixity they haven't mentioned over here. But they have given pre-epiglottic space. So it suggests always pre-epiglottic space suggests it is T3. Okay. So here what it is given? Epiglottis or epiglottic fold, but both the vocal cord is free from the mass. Two subset, it is T2. Okay, you got what is T2, what is T3. So in certain question, even I have seen what is T4A and T4B. They have given the explanation and they have told what is T4A and T4B. So how will you differentiate T4A and T4B? Remember, T4B is always, B means always you remember it is beyond. Okay, B means beyond. Where all beyond? Prevertebral space, carotid artery, and mediastinal structures. Beyond means far away. Okay, where all prevertebral space, carotid artery, and mediastinal space, it is 4B. But trachea, soft tissue of the neck, deep extrinsic muscle of the tongue, strap muscle, thyroid, esophagus, nearby outside structure. It is not larynx, come out of the larynx, but nearby, it is T4A. Come out of the larynx, not nearby, it has traveled beyond, mass is traveled beyond, invaded beyond. So it is called T4B. Okay, remember T1 you know what it is, T2 what you know, T3 what you know, T4 what you know. Coming to the management. So what all managements are there? So management for the supraglottic larynx, surgical management, supraglottic laryngectomy, extended supraglottic laryngectomy. For glottic, chordectomy, vertical partial laryngectomy, supracricoid partial laryngectomy, total laryngectomy. These are the treatment for the larynx. Okay, these are the treatment for the supraglottis. So what for T1, what you will do? T1 you will do the radiotherapy. Remember, always T1 you will do. There is a small lesion is there. You are not going ahead and removing it. It is radiotherapy. But what in newer advances, if there is an option is given, laser surgery or transoral robotic surgery, you should go ahead and mark those laser or transoral robotic surgery in T1. Okay, or else it is always radiotherapy. Okay. Then coming to T2. T2 in supraglottis, two subset only involved. It is horizontal partial laryngectomy. If T2 glottic, okay, it is vertical partial laryngectomy. Okay. Then T3, T4, it is always total laryngectomy. T3, T4, vocal cord is fixed, gone into any spaces. Okay, it will going to be, you have to completely remove the larynx. Then post-operatively you have to give the radiotherapy, chemoradiation. See, if there is an option is there, total laryngectomy plus chemoradiation, you have to go ahead and mark total laryngectomy or chemoradiation. Okay, not only the total laryngectomy. Okay, coming to this, what is this? This is the how it is horizontal partial laryngectomy is done. So where is the cut given? See, this is the vocal cord. Just above the vocal cord, they will take out the complete larynx. Okay, so it is horizontal partial laryngectomy. What is vertical partial laryngectomy? See, this much larynx they will remove. Okay, one side vocal cord, one side epiglottis, one side thyroid cartilage. This completely if they remove, it is called vertical partial. So any tumor extending here along this one, you can do it with a vertical. So for a T2 glottis, T1, T2 supraglottis, horizontal partial. Okay. So coming to this question, CT scan of a patient, carcinoma of larynx found to be involving epiglottis and false cord on right side, along with the involvement of right vocal cord and pre-epiglottic space. Okay, pre-epiglottic space T3. What is the treatment? Go ahead and mark total laryngectomy and followed by a chemoradiation. Okay, these all won't comes into the play at all. Okay, here it is involving two subset T2. So what is for supraglottis? It is a part of supraglottis. What you will do? You will do the horizontal partial laryngectomy. Okay, understood? Any question with the larynx malignancy? You can able to answer. Okay. So only thing is newer advances. If T1, if they give laser surgery, you should mark the laser surgery. Okay. Coming to the nowadays, this is most hot topic. They are asking the how will you do the post laryngectomy rehabilitation. Okay, well, you have taken out the larynx of the patient. So how will you do the rehabilitation? So remember, you might not have seen the how the laryngectomy is done. Okay, just remember, laryngectomy means patient won't be having hyoid bone, patient won't be having epiglottis or epiglottic fold, vocal cord, nothing. If you cross the base of the tongue directly, it is the esophagus or the piriformis fossa you are entering. Okay, you won't be seeing anything. So what happens over there? Everything they have sutured. And how the patient will get air? The patient will get air through the permanent tracheostomy. There will be a permanent tracheostomy will be there. You can't close at any time that tracheostomy. Moment you close the patient tracheostomy, patient will die. Okay, it is permanent tracheostomy. Larynx is completely knocked off. This is the question. Exact question is given for you in recent times. There are words are there which you haven't heard any time. But if you have the lateral thinking, complete laryngectomy has removed. So how can be a supratracheal prosthesis or supraglottic swallow will come? It can't come at all because there won't be any larynx is there. So supraglottis also won't be there. There won't be any supratracheal nothing is there. Everything they have sutured it. So how they will put prosthesis over there? They can't put a prosthesis. So all advice done or except you can go ahead and mark this one if you remember what is total laryngectomy. But since they have asked this question, next time they may ask detail about other things also. I'm going ahead with the what are the rehabilitation done in the laryngectomy. Hello.
Yes, Kartik, go on.
Audible, Allah?
Yeah,
Audible,
it's audible. I will stop if there is anything blocked. No, I will stop.
Okay. So what are the rehabilitation done? So to know the rehabilitation, what is the function of the larynx? You should know. Okay. What is the function of the larynx? Function of the larynx, main function. If they ask you in exams and all, you will tell phonation. No, phonation is not at all the function of the larynx because larynx is there in primates also. All animals will be having larynx. They are not phonating. It is always the protection of the lower airways. Remember, protection of the lower airways to stop the aspiration is the function of the larynx. Okay, so what you will do, whenever there is a so once the larynx is knocked off, means what will be having aspiration will never happen in the patient. Remember, in total laryngectomy patient, aspiration will never happen because larynx is taken out. Okay, so what all way you have to rehabilitate? You will rehabilitate by you have to give the voice for the patient, you have to give the olfaction for the patient because air is not going into the nose. Nose will become a rudimentary structure. So to rehabilitate, and pulmonary rehabilitation because the nose, what is the function of the nose? It will humidify and it will stop the small particles going into the lungs. Vibrissae and mucosa of the nose will protect from the lower airways. So that and all you have to rehabilitate, pulmonary rehabilitation. Then swallowing rehabilitation because they have removed the all hyoid and even the muscles, this strap muscles they would have removed. So elevation swallowing will be pharyngeal part of the swallowing is hampered, so that you have to rehabilitate. So what all you will do for this? So this is the question also they have asked. Post laryngectomy, person has undergone laryngectomy, the surgeon has put one prosthesis. What is this prosthesis? So it is the done for the voice rehabilitation. It is voice prosthesis. Okay, they will create a tracheoesophageal fistula. Okay, so the air will enter into this device and it will go into the esophagus. Esophagus will act as a vibrating substance and it will produce the airway to the upper part of the pharynx and the oral cavity, and patient can produce the sounds. So this is how they will do put this processes and they will make the patient to talk. Okay, so this is called voice prosthesis. Okay, so to do this one, what you have to do, you have to do the puncture the trachea and you have to open the put it in the esophagus. So it is called tracheoesophageal fistula. And this is one more device. This is called Electro Larynx. Okay, here you no need to do the tracheoesophageal. This what happens. This device detects the vibration of the esophagus and it will produce the voice. But here it will be a mechanical voice will be there. Okay, but here you can produce a little bit near normal voice. Okay, so this question they have asked what it is. It is a voice prosthesis. I will tell you the detail. They have asked even the name of it. So to do this one, what you have to do, you have to produce a tracheoesophageal fistula. Okay, you have to produce a fistula between trachea and esophagus. It is surgeon made fistula. Okay, see this one more device they have given. So I told you humidification you have to give. It is called, oh, I haven't put the name. Okay, it is called HME filter. Okay, HME filter. Okay, humidification they will use. They will just put it and it will act same act like a nose. Okay, it will give a warm air to the lungs. So it is called HME filter. Don't confuse with this to the this tracheoesophageal fistula. These are called tracheoesophageal fistula. What are the three types of tracheoesophageal fistula? They have asked. One is the Blom-Singer prosthesis. Okay, the down one they have put this picture and they have asked what is this. It is the Blom-Singer, Blom-Singer Blom-Singer prosthesis, voice prosthesis. Okay, singer means to talk. Okay, remember like that one. They will put it over here in the larynx. It is called Blom-Singer. Other one is the next one is the Provox. It is called Provox. Okay, one more is there Panje, P-A-N-J-E, Panje. It is Provox, Provox. Okay, these are the three tracheoesophageal prosthesis put for the voice production. This one is put for the pulmonary rehabilitation. Okay, warm air to enter into the lungs. Okay, sorry. Then coming to the voice rehabilitation, I told. Then pulmonary rehabilitation, swallow. Okay, swallow you have to, supraglottic swallow won't be there. There will be a forceful swallow will be there. So you have to, whenever the food reaches the pharynx, you have to tell the patient initial days forcefully swallow it. Okay, that is how we will do the swallow rehabilitation. Then coming to the polite yawning. What is called polite yawning? What they will do now? The nose is not getting any air. It is going through the tracheostomy only. So to get some air into the nose, then only patient can, it can reach the olfactory nerve and patient can sense the smell. What they will do? They will they will take the smell through the oral cavity. They will take the smell through the oral cavity. Then they will close the mouth and they will do the yawn-like thing. Like that they will do, so that the air will go into the nose and the patient can able to sense the smell. That method is called polite yawning, olfactory rehabilitation. So these all done. So post laryngectomy all advised except easy method. I told you this won't happen, but you know what is polite yawning, olfactory rehabilitation, tracheoesophageal fistula for voice rehabilitation, esophageal speech, Electro Larynx for the voice rehabilitation. Okay, this is not done. So this is the answer. Okay, so you know what are the rehabilitation. You know, remember these pictures: Electro Larynx, tracheoesophageal fistula, Blom-Singer prosthesis, HME filter. Okay, they may ask. Then coming to the next topic in the larynx, it is the benign lesions. So questions I will go. Most vibrating part of the vocal cord prone for trauma, vocal abuse is it is always junction of the anterior 1/3 and posterior 2/3. You can see over here vocal nodules has formed over here, anterior 1/3 and posterior 2/3. This junction is called most prone for the any trauma. Okay, so next question: a teacher present with a progressive change in voice associated with a voice fatigue. On examination, each vocal cord shows a symmetric lesion in mid-membranous part, likely the diagnosis. So another way of telling and junction of anterior 1/3 and posterior 2/3 is mid-membranous. Okay, this is posteriorly here the arytenoid vocal process will be there. This is the membrane. Okay, if you take the membrane, it will become a midpoint. Okay, if you take even the arytenoid part of the vocal process of the arytenoid, it will become anterior one third and posterior two third. Okay. So what is the, since it is teacher means continuously they will be straining their voice. So what is the answer? It is always the nodule. So when will become vocal cord polyp? If certain person is shouts single time, so they will give in a clinical scenario, a person gives a history of shouting at somebody, and immediately after that one he is having a hoarseness of voice or change in voice or voice fatigue. What is the condition? Only one time voice abuse is there, that always it is lead to the hemorrhagic polyp. There will be a injury to the vocal cord only one time it has formed at the sudden happening, it is hemorrhagic polyp. If it is teacher, continuously they are getting voice abuse, okay, they'll be continuously changing their voice and speaking, everyday strain will be there. Such patient will get a vocal nodule. Okay, teacher, singers, or somebody who is continuously speaking in a different tones. Okay, not in a normal tone. If you speak in a normal tone, nothing will happen. So in a class, if it is a huge class is there, they have to shout and speak. So they will be wearing their voice. So they will get this vocal nodule. Okay, one time there is a trauma, single time trauma is there, it is always the hemorrhagic polyp. Okay, remember in your scenario you should, and it is will give a symmetric lesion. Okay, symmetric means both sides same, it is always the vocal nodule. This won't be symmetric, it is always hemorrhagic polyp will be unilateral. Okay, then next question, 45-year-old smoker present with a harsh voice. Okay, harsh voice is, you should remember the word. Then low pitch. Okay, this also you should remember. Then vocal cord appears like a saddle bag. Okay, what is the diagnosis? It is always the Ringcase edema. Down picture you can see over here. So vocal cord has gone into a, forming into a bag like structure. Okay, they'll be moving like a bag like structure. So it is always, it is a Ringcase edema. Okay. So a singer noticed a change in her voice since past few weeks. She could not able to sing prolonged time as before, means suggest it is a voice fatigue. She is a singer, so she is changing her voice again and again. She was diagnosed having vocal nodule, so it will be vocal nodule. So following which is suitable mode of treatment for her. It is always, initial treatment is always voice therapy. Okay, don't go ahead and write I have told microlaryngeal surgery benign lesion. No, it is always the voice therapy. If voice therapy is failed after about 6 months and all, then you will give a you will do a microlaryngeal surgery. Okay, but for the polyp, one time trauma has happened, you have to do, there is no voice therapy, it is always the microlaryngeal surgery followed by the voice therapy. I have a question on it. So what is the treatment for the this thing, Ringcase edema? It is always cessation of the smoking. Okay, cessation of the smoking, then you have to see whether it stops or not, or else it is called reduction glottoplasty. If patient has stopped smoking, you have confirmed it, then how will you be, what you will be doing? There is a bag like structure, there is a edema is there, so how will you do? You will reduce the edema. So it is the word for the surgery for the Ringcase edema, it is reduction glottoplasty, glottoplasty, but you will be doing after the cessation of the smoking only. You have to confirm. In immediate next management is, best management is cessation. What is the surgical management if they ask for Ringcase edema? It is always the reduction glottoplasty. Okay. So coming to the best modality of treatment for the vocal polyp. So vocal nodule I told voice therapy, but vocal polyp is, it is always the not only microlaryngeal surgery, it is microlaryngeal surgery followed by the voice therapy. Okay, this is best one. Okay, then microscopic lens used in the microlaryngeal surgery. Which microscopic lens they will use in the microlaryngeal surgery? Okay, it is always the 400 mm. Okay, in ear it is 200 mm. In larynx it is always 400 mm. Remember it, just to sake of remembering. Then leukoplakia lesion on the vocal cord best treated by, this is, see here the leukoplakia. How will you treat it? So you have to best treated by the vocal cord stripping. You have to strip the vocal cord because there can be a chances of malignancy will be there. Just completely strip the vocal cord over here. Okay, it is, answer is vocal cord stripping. Any leukoplakia, erythroplakia, keratosis, if they give you, no. So what is the treatment is vocal cord stripping. Okay, diplophonia means dual voice is happening. Where all it will happen? It will happen in all condition. Okay, Ringcase edema, vocal cord polyp, dysphonia, plica ventricularis, in all condition it will happen. The following are the pre-malignant lesion of the vocal cord, except, okay, which won't lead to the malignancy. Okay, recurrent respiratory papillomatis, larynx malignancy can happen. Chronic laryngitis can happen. Keratosis, leukoplakia. I told you, we will strip it because to check malignancy only histopathology. So sulcus vocalis is not the pre-malignant lesion. Vocal cord is not. Vocal nodule is not a pre-malignant lesion. Vocal polyp is not a pre-malignant lesion. See here, it is the sulcus vocalis. You can see over here in this picture. See vocal cord, there is a sulcus, looks like a sulcus over here. So there is one more entity, pseudosulcus, where it will happen. Pseudosulcus means what? A part of vocal cord will go into the edema, superior part. So it looks like a sulcus is happened, but sulcus is not happening over here. Ingrowth has not happened. Okay, it has become, upper part has become edema. So you are seeing a sulcus over here. That is pseudosulcus, happens in a laryngopharyngeal reflux. Remember, in LPR there will be a pseudosulcus will happen. Okay. So this is recurrent laryngeal papillomatosis. Okay, caused by the human papilloma virus. Okay, how they will give scenario? A child comes with a chronic history of hoarseness. Okay, chronic history of hoarseness, previously treated. Okay, so what is the condition? It is always the chances of juvenile onset to recurrent laryngeal papillomatosis. What is the treatment for it? The treatment for it is the, right now we will do is the microdebrider, using the excision using the microdebrider, MLS plus microdebriding the whatever the papilloma is there. Okay, followed by, you can give a photodynamic therapy. I have a question on it, I'll just say. So how to differentiate between the pseudosulcus and sulcus vocalis? If you take a histology, this Rinke space, no, there will be a fibrosis, it will be ingrowth will be there. Okay, so only the sulcus vocalis will be there, but pseudosulcus there will be edema, upper part will go into edema, so lower part there will be, it will be normal, so it looks like a sulcus happening. It happens in a laryngopharyngeal reflux. Okay, treatment modality for recurrent laryngeal papillomatosis: phonomicrosurgery, interferon therapy, photodynamic therapy, all the above. So yesterday you might have heard about porphyria class. So porphyria is the condition, so we will use that condition. Just a minute. We will use that condition and we will make use of that condition, phototherapy. So we will give some phototherapic agent, something which is related to D-ALA. So that after that we will give a whichever range it will be having producing that photodynamic phototherapy, we will get that externally that phototherapy, so that the whatever the cells are there actively taking cells, that will die. So papilloma will die off. So it is how we will do. They will go into apoptosis. So that is how we will do the photodynamic therapy. Interferon therapy, since it is formed by the human papilloma virus, interferon therapy. Phonomicrosurgery will do a microdebriding of the whatever the mass is there. So all of them are the treatment for the recurrent laryngeal papillomatosis. Coming to the next question. 48-year-old businessman reported chronic throat pain and burning sensation in chest and occasional change in voice. His laryngoscopic picture is as below, and he has which of the following? So this is the his laryngo. This right side is the his laryngoscopic picture. So you can see there is between the arytenoid, you can see some growth over here. It is called mammaliation of intra-arytenoid area. There will be a pseudosulcus is there. See here how the pseudosulcus has formed. There will be a granulation in the arytenoid. These all are the finding for the laryngopharyngeal reflex. The word for it is pachydermia larynx. Okay, this is whatever happened over here. It is pachydermia larynx. This is mammaliation intra-arytenoid region, pseudosulcus, arytenoid granulations, red arytenoid. It is all seen in laryngopharyngeal reflux. Okay, so pseudosulcus, you know, Rinke's edema, you know, keratosis larynx. So this is how the picture of keratosis larynx will be there. This happens commonly in a smoker. Okay, keratosis larynx. Okay, what is the diagnostic finding for the laryngopharyngeal reflux? It is always 24-hour pH monitoring. So if they give this picture and they will ask what investigation is being done, it is 24-hour pH monitoring, and they will give, they may confuse you. So they will give what is the lower probe is just above the 5 centimeter above the lower esophageal sphincter. Above this above probe will be 1 centimeter above the low upper esophageal sphincter. Here 1 centimeter, here 5 centimeter. And how much pH is significant? Lower than 4. So they may confuse this 4 and 5, they will interchange. 4 centimeter above, 5 pH, like that they will give. So always you have to mark lower esophageal sphincter 5 centimeter. Remember, one you remember lower esophageal sphincter or 5 centimeter, or remember pH below 4 is significant. Okay. So, and they will use which scoring? They may ask you this one, de Maceter scoring. Okay, remember this de Maceter scoring. This picture you remember, it is 24-hour pH monitoring. Okay, 24 hours. See, this has been put and patient will be wearing this one. 24 hours he will be having this one, and finally they will take the reading and they will do the scoring. These all points they will do the scoring. It is called, don't remember scoring, not required. Only remember pH below 4, de Maceter score 5 centimeter above the lower esophageal sphincter, 1 centimeter above the upper esophageal sphincter. Here you keep just 1 centimeter. Here you need a significant reflux has to occur. At least that significance starts at the 5 centimeter. Okay. That is called laryngopharyngeal reflux, pachydermia larynx. Okay. Remember pachydermia larynx, keratosis larynx. Okay. So next coming to the trumpet blower complains on and off swelling in his neck, which increases while playing the instrument and reduces when you put a pressure on it, as in following picture. What is the diagnosis? It is laryngocele. You can see the swelling over here. They may give the picture and they will ask, it is laryngocele. So what you mean by laryngocele? Saccule of the larynx. This is the normal saccule of the larynx, or else called, it is called ventricle. This is the ventricle. This is false chord, true chord. Between that there is the space will be there. Why this space is there? It will produce the vocal cord will be devoid of any gland. So vocal cord, if I am speaking, no, my vocal cord will be getting dry. Just now I coughed because my vocal cord is getting dried. So I have to take a sip of water regularly. But little bit amount of that work will be done by the this glands present in this saccule. It will give moisten the vocal cord. So since it is there, sometime if you put a firm pressure, what they will blowing while they were blowing, no, the instrument, this vocal cord, they will close it. They will give a firm pressure and they will, vocal cord will suddenly open and it will, rush of air will happen and they will produce the that kind of sound. They can able to blow the that instrument. So this something hampering pressure happens means there will be air will go into like this and it can cause a laryngocele. Okay, internal part, it is internal laryngocele. It is once it comes out of the, they may ask laryngocele comes out of the which membrane? It is always the thyrohyoid membrane, not the cricothyroid membrane. Okay, they may ask this question also. It is always thyrohyoid membrane, external laryngocele. So Bryce sign, it is called, moment you press it, it will make a gurgling sound and it will reduce. It is called Bryce sign, BRYCE, or else it is called BOYCE, Boyce sign. Okay, both the signs has been asked previously. Okay, remember it. How to reduce it? You just excise it and suture it. Just excise it and suture it. Okay. Then coming to next question is pharyngeal pouch, or else Zenker's diverticulum. So they may give you old age patient, dysphagia, foul smelling, food regurgitation, belching sensation. On investigation, they'll give a barium swallow picture. They see this, there is a diverticula happening over here. It is called pharyngeal pouch, or commonly the one happens is the Zenker's diverticulum. So they may ask, Zenker diverticulum comes through the which part? It is always comes through the Killian's dehiscence. Okay, Killian's dehiscence is found by the where is this dehiscence is there? Where is this weak area is there? It is there between thyropharyngeus and cricopharyngeus. Remember, what are these thyropharyngeus and cricopharyngeus muscle? These are the muscles are the part of the inferior constrictor muscles. There are three constrictors: superior, middle, and inferior. So inferior has a two part, thyro and cricopharyngeus. Between these two part, no, there will be a deficient area will be there. That area is called Killian dehiscence. Through that, if there is a sudden pressure occurs or old age, there will be a weakness. So it may lead to the Zenker's diverticulum, or it will pharyngeal pouch. In a habitual, in if smugglers and all, if they give the question, a smuggler is having a pharyngeal pouch. If he creates man-made pharyngeal pouch to smuggle something, so they will do always between the superior and middle constrictor. Remember, superior man-made pouch. If they are, I am only creating the pouch by putting something on me, continuous pressure. I can reach only where the superior and middle constrictor. I can't reach the with my hand to the inferior constrictor. See, it is very below. Okay, so Zenker diverticulum is always between the inferior constrictor between Thyropharyngeus and Cricopharyngeus. But man-made smuggler, till now they haven't asked. If there is a habitual smuggler is there, he will create his own pouch into over there. It is between the superior and middle, remember. And they may give this picture. If they ask you, the surgery done for it is the Dolman surgery. Okay, remember Kashima, I told you for the bilateral abductor palsy. One more named surgery today I am telling is the Dolman surgery. It is done for the pharyngeal pouch or Zenkas diverticulum. This picture they may put and ask which type of instrument it is. It is called Weerda, W-E-E-R-D-A, W-E-E-R-D-A, Weerda laryngoscope. Okay, Weerda laryngoscope. What they will do, no, this above flange will go into the pharynx, below flange will go into the that diverticula, so they can excise the diverticula. So it is called Weerda, W-E-E-R-D-A, Weerda. Remember it is. Okay, Dolman surgery. Then coming to the last few slides regarding the congenital lesions of the larynx. Okay, they have asked recently. They have mentioned subglottic stenosis in the case, and they have told which grading it is. So you should remember by head this one, Mayer Cotton's grading. Okay, so subglottic stenosis, how they will give the question? Usually it will be a child. Okay, child and patient will be having a not immediate strider. Child has born, and after certain month age, child is starting having a strider. So it is slowly subglottic has become stenosis, that is idiopathic. Or else they will give a history of intubation. If child has been intubated, after certain day, after certain months, child is having a breathing difficulty. It is because due to the intubation injury, there is a subglottis has become stenosed, and they may give subglottis stenosis has been diagnosed. Which grade it is? So they have asked grading once. So remember, grade 1 is 0 to 50, grade 2 is 50 to 70, grade 3 is 70 to 99, complete obstruction is grade 4. Remember ulta, complete obstruction is grade 4, till 71 it is grade 3, 51 to 70 grade 2, 0 to 50. To pass, how much you need? 50 marks in your MBBS. So that is grade 1. 50 to 70, you just take it as a distinction. To get grade distinction, it is a grade 2. Beyond to get distinction, it is 71. So it is grade 4. It is first class. First class will be the grade 2. Okay. Grade 3 is the complete obstruction. They have asked this one. You should remember Mayer Cotton's subglottic stenosis. And even they have asked what is the treatment for it. They have put a mitomycin picture where it is used. It is used in the subglottic stenosis. After once you reduce this one, no, if you release this stenosis, after that one, it should not go again into the fibrosis and become stenosis. To prevent the restenosis, no, they will use this mitomycin. This is anti-fibrinogenic agent. It is also anti-tumor chemotherapeutic drug. So they have given option subglottic stenosis where it is used. Okay, they have asked even this picture. Moment you reduce this stenosis, no, what is the problem? Again stenosis can happen. Okay, how will you prevent it? You have to put some stent. How will you put this stent? Through the tracheostomy, you have to put this stent. This above part will go above where the stenosis is there, below part will remain down. So it is called Montgomery T tube. They have asked this one. Remember this picture they have put and asked what is this and where it is used. It is used in the subglottis or tracheal stenosis. It is Montgomery T tube. Okay, remember this. Remember Mayer Cotton's grading. They will give usually child coming to with a strider. After they will give at least there is give intubation history they will give, or else will give at least a 4 or 5 month old child. Okay, okay, they will give like that one. And sometimes they will mention even subglottic stenosis in the question. Okay, so then coming to the 2 months infant has had inspiratory strider since 1 month of life. Immediate. See here it is subglottic, I told, beyond they will give. So here it is called since first month of the life, immediately after first month birth only, but has been otherwise well. Apart from this problem, there is no other problem is there, only inspiratory strider. Physical examination is unremarkable. Okay, except moderate inspiratory strider. Retraction, which is worse, remember this, which is worse, patient is in supine or crying, which reduces on prone. Moment the point comes, reduces on prone, increases on crying, always go ahead and mark laryngomalacia. Okay, always reduces on prone, increases on crying. If the word is there, go ahead and mark laryngomalacia. Okay, what are the condition? Laryngomalacia. You will see omega shaped epiglottis. Okay, it will be usually newborn, immediate month of the birth. Stridor will be there, inspiratory stridor. Increases on crying, reduces on prone position. Okay, what is the immediate treatment? You have to reassure the child. Usually by the age of 3 to 4 months or later life, 6 months and all, it once the laryngeal structures become properly grown, means it laryngomalacia won't happen. So when you will do the surgery in laryngomalacia, repeated cyanotic spells are there. Remember this word, repeated cyanotic spells. Failure to thrive is there. You are then you have to take a pediatrician opinion and you have to surgery is indicated in the patient. So what surgery you will do? It is called supraglottoplasty. What you will do? You will just evaporate this ariepiglottic fold. Okay, see, laser evaporation of ariepiglottic fold has happened. So what happens? This collapse won't be there. Air will directly go like this. Otherwise, it will collapse. So you take out this ariepiglottic fold over here. So it is called supraglottoplasty. When you will do repeated cyanotic spells or failure to thrive. FTT is failure to thrive. So, so your question may come. What is the? They will give all history of this laryngomalacia, and they will ask what is indicated. They will tell laryngoscopy is indicated. No, laryngoscopy is not indicated in laryngomalacia because you can diagnose by the history only. Classical history will be there. If there is a failure to thrive or repeated cyanotic spells are there, you go ahead and investigate what is happening over there. If there is a laryngomalacia, you see, then if failure to thrive cyanotic spells is there, then you have to go do the supraglottoplasty. Okay. So which of the following is not a feature of laryngomalacia? Usually present from the birth. Yes, it is a feature. Tends to get better after 3 to 4 months. Yes, it is a feature. Should always be investigated with microlaryngoscopy. No, not required. Okay, by classical history only you can get to know. Is due to prolapse of tissue into the larynx during inspiration. Yes, that is only happening. So only you will be knocking off the ariepiglottic fold. So supraglottoplasty cause inspiratory stridor. Yes, obviously it will cause. Which of the following is not a feature of laryngomalacia? Usually present from the birth. Tends to get same only output. Okay. Which of the following life-threatening congenital anomaly in newborn present with a pachydermia, aspiration pneumonia, excessive salivation, difficulty in passing the nasogastric tube? It is always the tracheoesophageal fistula. Okay, answer is tracheoesophageal fistula. Because they are written here aspiration pneumonia. If there is aspiration pneumonia is not there, if there is a salivation is also not there, difficulty passing the nasogastric tube, it is the choanal atresia. Okay, immediate after that bilateral choanal atresia is there, patient will immediately sinuses. If I will tell in nose class, if bilateral choanal atresia, what is the treatment? Immediate treatment is McGuerin nipple. I will tell in the class when I take nose. Okay. Then stipple sign, it is seen in laryngotracheal bronchitis, or it is called croup. Okay. Then a child with a fever and barky cough presented to the emergency at 3 a.m. His respiratory rate is 36, stridor only on coughing, fever 39 degrees Celsius, no other abnormality. What is the next logical step? So what you will do? Dexamethasone, racemic epinephrine, do nothing, just reassure, give surfactant. Surfactant won't happen because immediately after birth you will give. So racemic mixture usually will give in a epiglottitis. Fever they have told 39 degrees Celsius, almost near normal. Stridor only on coughing. It is laryngotracheal bronchitis. It happens due to the edema in the subglottis. So what you will give? You will give a dexamethasone. To reduce the edema, you will give a dexamethasone. Okay. So this completes today's class on larynx. Any doubt you can ask. These are the most questions asked in recent times. Okay. Hello.
Yes, yes. It was very wonderful class. I think students can tell anything if they want any change in the class, and was it beneficial, useful, not useful, or how you want to change this. And it is better if you send any MCQs to Kartik personally. If you have any while reading, if you get any MCQs, so that we can pull it and discuss it during the revision. It's not that we teach anything new here. It's just that we are enabling you to revise topics, revise things, so that you can concentrate on other subjects, like more questions which give more weightage. like more number of questions in medicine or surgery, you give more time to those subjects so that you can get those questions right. It's all like every day you learn something new and we help in revising things. You have to give feedback in the group, preferentially in the group, like how was the class and all. That will inspire us to make our class better or preparation better. Kartik, you have done a wonderful job and wonderful work.
Thank you.
To make this very interesting. So you can also share in the group. I will share the video in the group so that more people can get benefit out of it. So if there are many questions in larynx, if they post more questions to you, that we can discuss some of those questions also. So what you can do is today or tomorrow, people can revise larynx, and then so that this will get into your short-term memory and keep on revising once in third day or fourth day. So next class he will take up, if anything larynx is left, we can go to pharynx or other things. What is your plan, Kartik? Like next class, what do you want to take up?
Next class I will take nose, because I have seen